It's an honor to be here and to speak to you, and I appreciate the opportunity to tell you about pneumatic compression. As I start, I'd like to just tell you a little bit about my background. After I received my CDT training in 2003, I was very I would say prejudiced against pump use by my teachers and felt that it was harmful and avoided using it. And it wasn't until one of my patients who was participating in a study at Stanford, which is near our clinic, she came to me and said, you know, I've been using this pump at home and it's really been helping me. So I felt obligated as a professional to check it out. So at the next National Lymphedema Network conference, I went to the various booths and checked out the pneumatic compression devices, and from then on started to look at the research and the evidence and use it in my clinic. And I found that incorporating it into CDT treatment has been very, very valuable, both in clinic and for home treatment. So my caveat here is that it's good to have plenty of tools in your toolbox. And initially, I wasn't using the pump, and I feel that it's not a magic bullet. It's not the only treatment, but it is a very, very valuable tool. So if you haven't used it up until now, I would encourage you to check out the research, and Tracy did a very excellent job of talking about lymphedema and lymphedema research, particularly as it relates to pneumatic compression. So my feeling is that pneumatic compression really helps in the clinic to accelerate the reduction phase. If I'm going to be working with CDT and trying to do the bandaging process to help patients reduce, if I use pneumatic compression prior to bandaging, I find that it can be time-saving and even more comprehensive than MLD in the initial reduction phase. It complements MLD. I still use MLD extensively in the clinic, but I will often do MLD simultaneous with pneumatic compression. I also find that working with fibrosis, pneumatic compression is very, very useful because in patients who have heavy fibrosis, the superficial lymphatic vessels are often damaged, and the patient is relying on the deep lymphatic collectors, and using the more aggressive, deep pressure is actually very, very effective for these patients in both softening the fibrosis and helping to reduce the lymphedema. And as I mentioned before, increasing therapist efficiency. We have a waiting list at our clinic of about 100 patients. And what we find is that our goal is to make ourselves as clinicians obsolete as quickly as possible. We want the patients to have a good home program to managing their own lymphedema symptoms. I think it's very important that as clinicians that we do proper trials in the clinic to assess the appropriate course of treatment for our patients, both in CDT and pneumatic compression. So to give you some examples, these are some slides that show, and I'm going to go fairly quickly because I know we're short of time, but these are examples of patients that have used pneumatic compression as part of their CDT treatment. You can see that this is a case of primary lymphedema, and you can see a profound reduction in a very, very short time. And with the very, very difficult patients that have the massive lymphedema, this can be very, very helpful. Another example of post-traumatic edema. And here are some slides that really show the sclerotic changes that Tracy was referring to in fibrosis, and how the use of pneumatic compression is very, very useful in addressing the changes that can happen potentially to soften tissues. So why use pneumatic compression? Some studies have shown that it can be as effective as manual lymph drainage, that it costs less over time, and there can be more reliable outcomes. The way that pneumatic compression reduces lymphedema is by increasing the uptake of the lymphatic capillaries, causing them to take in lymphatic fluid, and it directs it proximally. A lot of therapists have been told that pneumatic compression is dangerous, and as Tracy pointed out, I think that used incorrectly, it can be harmful. We'll talk more about the evolution and touch on that briefly, but there's a myth that manual lymph drainage moves lymph and that pneumatic compression moves water and leaves behind proteins. And there have been some different studies on this. Parch showed in 1980, measuring albumin levels, that pneumatic compression actually did decrease the protein level in the limb, but that it was still increased overall because in those cases, the patients hadn't been completely reduced. There's another reference by Dr. Schuba that looked at functional outcomes of patients with pneumatic compression, and they found functional evidence, including range of motion measurements and tonometry, that indicated that it appeared that proteins were being moved as well as water. There was a study done by Boris years ago that looked at genital edema, and that was a study that used the extremity sleeves only. And that's the old style pump that Tracy was referring to. So fortunately, we have these advanced compression systems that cover not only the extremity, but the genitals and the abdomen and the torso as well. So really, with the new compression systems, genital edema is actually treated by them. There's been concerns about using high levels of pressure, and I think that as clinicians, we need to determine our clients' tolerance. Many patients have fragile skin, they have wounds, they have other comorbidities that necessitate lower levels of compression, and I always advocate starting with the lowest levels of compression. But I go by client tolerance, I look at the tissue, I assess overall, is this level of compression effective for a patient, and try to match the level with the patient's need. There have been studies that have shown up to 100 millimeters of mercury, which is way in excess of what we use in the clinic, has been effective in pneumatic compression. So that argument I found in the clinic is not really valid in terms of fear of high levels of compression. I would say the highest on an average that we use is around 60, and those are for the patients that have higher body mass or higher levels of fibrosis. Another myth is about treating bilaterally. And I think with patients who have cardiac issues, it's very important to approach it cautiously. If I have someone who has a problem with congestive heart failure, I will start compressing half a limb and then progress to a full limb. And if it's bilateral, then go to the other side. So I will go progressively. But with your average patient who doesn't have cardiac issues, we do a lot of aquatic therapy. In Santa Cruz, California, we are lucky to have a lot of swimming pools, and both indoor and outdoor. And I don't mean to brag, but when I left home on Tuesday, it was in the 60s, which I guess in centigrade translates out to what? Teens, 20s, anyway. But whether people are indoors or outdoors, we encourage a lot of treatment in the water and have found that that is very, very effective. It's one of the most effective modalities that we have and is even more aggressive than pneumatic compression. So I think it's good to use caution with certain patients, but in general, using pneumatic compression over 2 limbs and part of the torso is excellent for most patients. This is just to illustrate the level of compression in water. For a patient that is standing in about 3 feet deep of water, the compression at the feet is about 75 millimeters of mercury. So that's actually in excess of what I would use in the clinic. So I just have some little diagrams that show how pumps evolved. The picture that Tracy showed of the single chamber pump, basically it just compresses the entire limb all at once. There's no direction to the compression, and so fluid can move both proximally and distally, which can be very harmful. So these pumps are no longer in general use. And I'm going to whiz through these slides. I understand that you might be able to get access to these as part of your handouts. So the next one that you can see, the E0651, and these categories, by the way, are the ones that Medicare uses in the United States to classify pumps. E0651s are still used widely in the US. These are the 4-chamber pumps, and they move directionally. So the most distal chamber inflates first, and then so on until they're all inflated, and then they all release. And I primarily use these pumps for phlebolymphedema, or patients who have bilateral lower extremity, generally below the knee, and they can be very, very effective for this because in those patients, they don't have proximal involvement in their inguinal lymph nodes or the deep collectors in their abdomen. It's more circulatory in nature. So that would be the place for this pump. But in post-cancer treatment, then we want to really look at the E0652, which are the pumps we'll be looking at today. They're the advanced compression systems, which direct the fluid out of the extremity and then through the trunk to create the anastomosis to redirect the fluid out of the damaged areas. So looking specifically at lymphopress, the appliances or garments that we're going to be looking at today have 12 to 24 chambers, with the exception of the lymphopod, which has 40. And these chambers overlap. I'm going to show you a slide here of how these chambers are about the width of a short stretch bandage or the palm of the hand, and they overlap. And so there's a simulation that is not manual lymph drainage, but is mechanized and as close to manual lymph drainage as you can get with a machine. The advantage is that you can deliver the same treatment consistently every single time. So as the clinician assesses the patient and their needs, they can give the exact protocol and setting for each patient. There's not a cookie cutter treatment. It really does need to be individualized. And we'll talk more about that. It has a very quick cycle time, so you don't have a tourniquet effect when you inflate all the chambers. So just the indications of use, and Tracy talked quite a bit about this already. And the contraindications, which again, you should have a list of these in your handouts. I think it's very important as you assess each patient that you rule out these contraindications. And as Tracy mentioned, there are absolute and there are relative contraindications. And that with the relative contraindications, it's important to discuss this with the patient's physician, medical team, and take the whole picture into consideration, because under some circumstances, relative contraindications can be managed. These are just some ICD-9 lymphedema codes. I don't know if you use these in Canada, but these are the coding that we use in the United States for lymphedema, as well as the causative diagnoses. And I'm whipping through these because they're in your handouts. So it's very important to individually assess every patient that is a potential candidate for pneumatic compression. I start with the medical history because that helps me to look at the contraindications and make sure that they are an appropriate candidate. I look at all of their surgical history as well as their comorbidities. It's very important to me to look at their pain and their sensation levels. If they are insensate or have paresthesia in an area, it's very important for me to monitor even more closely how this affects them. I want to know what their skin condition is like, whether they have wounds, if they have fibrosis, scarring, because again, I take all of that into effect when I'm looking at their whole CDT program as well as their pneumatic compression program. I think it's also important to take baseline measurements so that you can see what is the level of edema circumferentially prior to starting this treatment. And then I always make sure that we do wound care as needed because, as Tracy mentioned, pneumatic compression can be a very, very effective treatment for wounds, but if the wounds aren't dressed correctly, it can get kind of messy. So looking at treatment parameters, we're going to be looking at all of this that I mentioned before. We're going to be taking into account how much treatment time, which may vary as we progress in patient treatment, and same thing with treatment frequency. So I think the takeaway from this slide is just that it's individualized for each patient. So we're going to be talking about the garments or the appliances that we use along with the pump. And I was very fortunate to be involved in the design of some of these garments. The manufacturer, Mego Afek, from Israel, sent out one of their designers to my clinic in California twice, and we helped work with the design of both the lymphopod and the comfy sleeve, and beta tested both of these garments in my clinic. So there's been a lot of patient and therapist input into the design of these garments. Okay, there we go. So if we have a patient who has a single arm and a trunk affected, which is, I would say, the bulk of my caseload, the majority of the patients that I see have breast cancer-related lymphedema. It affects one extremity, the arm, and the trunk. Very oftentimes, they will have swelling in their armpit, in their chest or breast if it was a lumpectomy, very frequently in the shoulder or the back. So we are looking at a comprehensive treatment of that upper quadrant. And this is just a picture of the comfy arm sleeve, which we'll see demonstrated shortly. And this would be the appliance of choice for that type of patient. Less commonly, I will see patients who have bilateral mastectomies. And this slide is a patient of mine who had bilateral surgery and reconstruction. And she developed lymphedema in her trunk because of the form of reconstruction. It also affected her abdomen. And you can see here she's modeling a very ultra-custom Jovi quilted garment that she wears at nighttime. And we don't have time to get into anti-fibrotic treatment, which is one of my big passions, but I use chip foam garments nocturnally extensively for treatment of fibrosis and find that the combination of the chip foam and the pneumatic compression over time as part of a patient home program can be highly effective in softening fibrosis. So this is the LymphaJacket, which, as you can see, has the capacity to treat both arms and the torso. So this would be the appliance of choice for the patient that you just saw that had both upper quadrants affected. This is actually a slide of a patient that mainly has phlebo lymphedema symptoms. You can see that there's some erythema in the lower legs. She could, it's hard to tell from this slide whether it's body mass or edema in the upper legs. She would be a candidate for the next appliance that I'll be talking about. I'm going to give several slides that show conditions that could benefit from the LymphaPants. This is a picture of a gentleman with genital edema. He had prostate cancer, and you can see that he has that typical appearance of swelling of the genitals, but also the greatest amount of swelling is just below the inguinal lymph nodes, and then less swelling as you get down to his feet. And we use the LymphaPants quite successfully in combination with garments and CDT to treat his genital edema. This is an example of a wound in a patient that I saw that had venous problems. And using pneumatic compression with wounds can be very, very effective to help the circulation to accelerate wound healing. So this is an example of the LymphaPants garment, which treats two lower extremities, the abdomen, the lower torso, and genitals. Here's an example of one of my bariatric patients. And these are patients that oftentimes will also have lipedema. And we use a special lower extremity appliance called the LymphaPod to treat patients that are too large or have special needs and are not appropriate for the LymphaPants. So this is an example of the LymphaPod. So as I mentioned before, when we're doing trials in the clinic, we're going to start with lower pressures. We're going to increase pressure if we see that the patient needs more compression because they're not getting a response. The patient should always feel comfortable during treatment. I use patient comfort as a indication of my upper level of compression. I do not exceed a level that allows a patient to feel pain. The patient should always feel comfortable with this. And if they do feel discomfort, oftentimes looking at their position in the appliance, looking at, what are they wearing underneath, what is their body position like? Sometimes with some of my upper extremity patients, if we abduct the arm a little more or position it in different places in space, some of my arthritic patients who get very stiff will oftentimes want to move partway through the session and adjust their arm position. So there's a lot of allowances that you can make to compensate for individual patient circumstances. And of course, reducing compression, if that alleviates patient discomfort, then that's a sign that you want to stick with the lower levels of pressure. So I'm going to refer you to your handout because we have created a comprehensive handout that I understand you have access to that gives some guidelines in terms of how to select pressure for different scenarios. So as we do the treatment session, we want the patient's limb and torso to be covered. It can be covered either with clothing or stockinette. In our hospital, we sterilize the appliances between uses of patients. So part of the purpose of having the limb covered is hygiene, but part of it is patient comfort as well, so that it's not in contact with the appliance. We do the trial for about a half hour initially. We might do it less time if a patient has special circumstances, such as wounds or fragile skin. And after the treatment, or even intermittently, you want to check the tissue, look at what's happening in terms of the reduction, how does the skin look, how does the patient feel, and make sure that there are no adverse effects. So I'm going to whip through this in interest of time because we want to get to the appliances, but I'm going to refer you to your handouts in terms of developing an overall program for patients. In the US, in order for a patient to qualify for a pump at home reimbursed by insurance, most patients have to have a period of time of what we call conservative treatment, which is using CDT, emphasizing compression, manual lymph drainage, elevation, and exercise, as well as meticulous skin care. And if that fails to adequately affect edema, then patients are able to do a trial with pneumatic compression and might be qualified to start using a pump at home. So using the lymphopress systems. This is what the pneumatic compression device or the pump device looks like. This is the optimal, and it's highly programmable. It has many different options that we'll be going over. So there's a wide range, as Tracy mentioned, of compression that's available. And I always say less is more. If you start with the lower compressions and then go up depending on patient factors, you have a lot of variety in what you can do. There's also a lot of variety in the cycles. You have 3 basic different options. There's the pre-therapy option, which starts to clear the trunk area or the abdomen area initially, and that goes on for about 10 minutes of the cycle. It's interesting to note that the pre-therapy, the maximum compression for that is 40 millimeters of mercury. So that's standard no matter what you choose for the rest of your programming. So you can choose to program with or without the pre-therapy cycle, but I generally like to use the pre-therapy because that follows the principles of manual lymphatic drainage. In addition to the pre-therapy, you will be selecting either sequential or peristaltic. And the difference between those 2 cycles is sequential is where each chamber inflates in sequence and they are all held until they are all full, and then they all release at the same time. That's used more for lower extremities or for severe fibrosis. I tend to use more of the peristaltic programming in my clinic because that's better tolerated. And the peristaltic program is where one chamber inflates and then it releases as the next chamber inflates. And so it's basically creating this directional motion that is much more consistent with manual lymphatic drainage. So we're going to talk about programming the optimal, and for patients that use this at home, they will be able to adjust the treatment time, they will be able to lower the treatment pressure, but the upper level of pressure is locked by the clinician. And I'll show you how to program that in the clinic. It's possible to program either directly on the machine or with a computer. I find that with the computer, you can get very exacting levels of gradient, but in general, I tend to use the 4-zone method in the clinic, which is what we're going to be demonstrating today. So again, to reiterate, the advantage of the extremity torso garments is that they will work with the torso as well as the extremity, which is very, very different from the traditional pumps that basically gave pumps a bad name. This is a whole different world. I would say the last 10 years with the advent of the advanced compression devices and appliances, we're seeing so much more effectiveness because they are preventing cuffing of fluid. And again, I want to reemphasize that an extremity-only sleeve with a patient who has proximal swelling is not appropriate because you're pushing swelling into an area that is also affected by edema. So it's very important for patients who have swelling in the torso to use a garment that treats the torso. And using the pre-therapy program helps to clear the proximal lymphatics, similar to what we do in manual lymph drainage. So I'm going to whiz through this quickly in interest of time because I'd like to get to the demonstration. But the comfy arm sleeve, or comfy sleeve, this, in your handouts, we'll talk about what it does and how to use it and how to adjust it. So I think maybe what I might do is just leave this slide up and call for my first assistant. And what we will be doing is actually showing you how to put this on a patient and how to adjust it. So we're going to be treating the left upper quadrant, and you can see that there is a panel here that can be unzipped. And we have different panels for the left side and for the right side. So depending upon the patient need, also depending upon the size, you can get these in larger or smaller sizes. Now you're very petite, so this is going to be a little large for you. But this can be done in a seated or a supine position. Many of my patients like to take a nap after they've gotten used to this. Many of my patients like to watch a television program, and they'll do their treatment at home for about an hour. In the clinic, we do the treatment anywhere from 30 minutes to an hour. And so we start by having you, let's bring your arm in here. And we're going to bring this around the body. And there's Velcro tabs here that allow for ease of use. This arm sleeve will actually unzip. So if you're doing this on your own at home, you'll have 2 hands free to be able to use the zipper and adjust the straps. So these straps can be adjusted. And generally, what I do is, prior to zipping it up, I will put the straps all in the slack position so that there's plenty of room and slack for a patient to be able to join the zipper together. So this is one side of the zipper. It's actually on the area with the straps. The other area is down here at the bottom of the garment. Oftentimes, we'll put a ribbon here so that it's easy to see. Just thread it through the end of the zipper. Okay, and this is a brand new garment, so it's very stiff, but would you like to go ahead and just zip the rest of this up? Perfect. Great. And then the straps are adjusted. And I would say that it's good for them to be snug, but this, in the de-inflated state, is not a compression garment. So it will inflate to fit. And so you want it to be snug, but it doesn't have to be tight. The other thing that is important, and this was already done, but if you're doing this for the first time, one of the great features of the comfy sleeve is that it has a chamber in the axilla that inflates up into the axilla. And it's important that that be positioned so that it's aimed straight for the axilla. And I'll show that to you after we take this off. So I would just kind of sort of adjust it around again, readjust straps if needed, and then she can go ahead and zip the sleeve back down again, and she's ready to go. So rather than, in the interest of time, go through a whole treatment session, I'm going to be talking more about getting in and out of the garments and programming the pump. But you can see that if you want to go ahead and unzip this, yeah, and you can unzip that arm. She can even do it one-handed. I mean, this is very easy for people to get on and off. Yeah, that's great. Perfect. Okay, and you can stay where you're at. And this right here is the axilla chamber. So you want to make sure that it's not folded back, otherwise it won't do any good. You want to make sure that it's aimed right there into the axilla. And this was something that I was very excited to see develop. This is not part of the bilateral lympha jacket. This is what gives the comfy arm really an edge. So we'll also take a look at the jacket. And this has a zipper panel that can unzip on the left or the right, depending on whether the patient is left-handed or right-handed. Similar to the comfy sleeve, the arms can unzip so that patients can put it on themselves if they are using it at home. One thing about the bilateral jacket is that it covers both arms and hands. So it's important that if a patient has edema in both hands, you want to cover them. But some of my bilateral patients will maybe be more affected on one side, and they might not necessarily have edema in one hand. So there is a way that you can use this with this partly zipped, or there are also, where are they? There were some little plugs a minute ago, but it's possible to plug hoses so that these distal chambers don't even inflate. And this is advanced use. I would say that there's a lot of versatility in where you apply pressure. There are chambers that go throughout the arm and torso. And say if you have a patient bilaterally who has a port cath, for instance, let's say they're still receiving chemotherapy infusions, you can actually plug chambers right over a port so that it's not inflating right over that. So I'm going to just have you model this. Go ahead and stand up. And you just slip it on like you're putting on a jacket. And you can have both your hands free. And you'll be looking for the zipper here at the bottom of the straps and the other end of the zipper here. And up it goes. And as it inflates, I think it's important to make sure that the jacket goes up into the axilla area. And you can see how, she's very petite. So in some of my patients, what I will do is to use a beanbag pillow, a sandbag type pillow that will help to conform the neck and the shoulders to the patient while they're having pneumatic compression treatment. Go ahead and sit down. And you can go ahead and take that off. So it would be similar with the comfy arm in terms of adjusting the straps and so on. So if you can help me hold this up, I want to show you that there is a zipper down the back. that can be unzipped, and there can be panels inserted. So if you have patients who are quite large and you want to focus the compression over the front of the torso. And so adding a panel in the back will expand the jacket to make it larger while still allowing the chambers in the front to be activated. Oftentimes what people will do is they will extend the straps, but then you have a whole area in the front of the body that's not getting treated. So my preference would be to use the expanders in the back so that you can focus more treatment on the front of the body. The other thing is that the patients will perceive more compression in the back because oftentimes the weight of their body is lying on a table or a bed or leaning against a chair. So they will sense more compression in the back because they are actually, the weight of their body is providing even more compression on top of these chambers. Thank you very much. So I'm going to call for our second assistant, Megan. And Megan's going to help me demonstrate the lower body garments. So I'm just going to, I think in the interest of time, we're going to have more videography this afternoon where we'll be able to look at the lymphopod. But because we're very short of time today and we want to allow time for questions and answers, I'll just show you very briefly the lymphopants. And one of the things I love about the lymphopants is that they have so much versatility. There's 3 different zippers, so depending upon the size of a patient, you can adjust it to be tighter or looser. And of course, you can use expander panels, as you can with the jacket, to make the pants larger if needed. The other form of adjustment is that there are zippers here for the heel of the foot. So you can open this so that the foot is not driven into plantar flexion. You can actually allow a comfortable dorsiflex position here. So when I set a patient up with the pants, what I will do is I will zip it up part way, and we've got these air hoses in the middle. So all right, so this is like getting into a sleeping bag that has chambers for both legs. So Megan, if you'd like to come around. And this table's kind of high, I apologize. Yeah, go ahead and slip your boots off. Some patients will actually use these appliances over their compression garments. I'm cautious about elastic garments because with patients that have fragile skin, sometimes pneumatic compression over an elastic garment can create binding. So I would be cautious about that. But I do use them extensively with the quilted garments because they don't have that danger. So this is kind of high, but could you go ahead and climb up? And she's going to put her legs into each sleeve of the appliance. She's going to scoot up so that this part actually, keep scooting, is even with her groin. That's perfect. Now you can go ahead and lie down. Okay. And again, in the interest of time, I'm not going to adjust the side zippers. For her, I would probably be using the closest zipper because she is also very petite. You comfortable?
Yep.
Okay, and as I said before, I would adjust the zippers in the heel. I would find her heel and set the garment, and then use a little pillow at the end to help maintain her foot in dorsiflexion so that it's more comfortable. And I would do that on both sides. So that's the lymphopants. The pod is very similar, but it has some other design features, and we'll go into that more this afternoon. So let's get you out of this. And I'm going to show you a technique that I use in the clinic for patients that are maybe first using the pump, and especially with people who have less mobility. You can very gently bend this knee and lift your foot a little. And then on this side, excuse me, bend this knee and lift your foot. So what I'm doing is to position it so that you could just lift your butt and it'll slip out. So that's a very easy and fast way to help a patient out of the lifted pants in the clinic. Thank you very much, Megan. There are extremity sleeves that are available for use with the Optimal, but we're not going to cover those today. And I would say for the purposes of our lecture, we're really focusing more on the extremity and torso. So in conclusion, I want to thank you for your attention and thank you for opening your minds to the possibility that pneumatic compression could benefit both you and, most importantly, your patients. Thank you.